thank you very much for taking your time and being here with us today. It's a pleasure to have you here.
It's my pleasure to be here.
Before we start with the interview, I would like to ask you to shortly introduce yourself and tell us what you're doing exactly.
My name is John Glover. I'm an osteopathic physician, and in the U.S. that means a fully licensed medical practitioner, as well as doing osteopathic manipulative medicine. Currently, I actually retired twice, but because of personnel things, interest and changes at the school, they've asked me to come back and help with teaching. So I'm teaching at Touro University in California.
You personally got quite a CV. Your career started with a master's degree in biology. So why exactly did osteopathy spark your interest?
Osteopathy has been an interest, not for a lifetime, because most of the time that I was growing up, I had never heard the word. So during the period of 1962 to 74 in California, there were no osteopathic physicians licensed, zero. And anyone from anywhere in the country could convert their license to an MD license that was only valid in California. So it basically wiped out the profession in California. So growing up as a high school student looking for careers and that sort of thing, it never entered my mind because I never heard the word, I never saw it. And it wasn't until later when I was teaching in Virginia at a small rural community college, I hurt my back, started looking at options in terms of treatment and came across osteopathy. Couldn't find an osteopathic physician to treat me, so I actually went to a chiropractor who tried to convince me not to go to osteopathic medical school, but that's where the interest came. I read about the philosophy fascinated me. I loved the integration of traditional medicine combined with the hands-on diagnosis and treatment. So that was really what brought me to osteopathy, was traditional medicine didn't interest me. I didn't like the way it was carried out, the way I had received it in terms of the physicians I had been in contact with, but I liked this integration between the hands-on part and the more traditional part of medicine. So that's what really brought me to osteopathy, was a back injury and the integration of hands-on diagnosis and treatment combined with medical care.
And how exactly do you treat your patients in your clinic personally? Like, for example, how much do you value intuition and standard medical care, let's say?
That question, the answer changes over time. So for instance, when I started, my goal was to be a family physician that integrated osteopathic manipulative medicine into the care of their patients. And I did that for about 5 years, and what happened then was there were plenty of osteopathic family physicians around, so they didn't need my family medicine physician skills as much, and my patient load for the manipulative work was backlogged over 3 months. So I said, I've got to change something. So I started carving out days in the week, and it got to the point where my family medicine patients couldn't get in to see me for a week or two, and that doesn't work well in the American system. So I then shifted over to just doing and specializing in osteopathic manipulative medicine. So since then, I've done that, and I've always combined seeing patients with administrative work. I've been chair of a department at several schools, and then also doing the teaching, which is what I truly love the most.
And one of your teachers during your studies in osteopathic medicine was Dr. Lawrence Jones, the founder of the strain-counter-strain techniques. How exactly has he influenced your work?
Dr. Jones has been an influence ever since I met him as a student. So he was back when I was a student at medical school in West Virginia. He came as a visiting lecturer and presented the counter-strain method to our class, and I loved it. I loved the palpation, and I loved the results that I was getting from it. And so we got to be talking in between breaks, and then eventually, as he had come back, I did an osteopathic teaching fellowship, which gave me another year to teach before I graduated from medical school. And one of the opportune times was I actually came back. I was doing a rotation, obstetric and gynecology rotation in Michigan. I'd come down back to West Virginia to take a weekend workshop from Dr. Jones, and he was going back to visit a friend in Ohio, so he said, would you possibly be able to give me a ride? So I said, sure. So we had a long ride from West Virginia to Ohio, where we got to talk, and that was where we really got to be friends. And over the years, we've worked together in teaching and talking about ideas with osteopathy applied through the counter-strain model, and it just all clicked and worked out well. So Dr. Jones has been a big part of my life. He also contracted prostate cancer, unfortunately, at the end of his life. And we worked together at Ohio University in terms of trying to record his work, so it was all in one place and done digitally. And that gave him some ideas about teaching, and he had a year of remission, and that's where he did the second book that he did, was during that time period when he was remission. And then when he came back from vacation in Costa Rica, I saw him at the AAO convocation, and he literally looked like death warmed over. It worried me a lot. And I had tried to get a award given to him that was the highest honor of the academy, and he needed a few signatures and this and that. So I asked the president if we could have a special meeting of the council, and we met. Everyone agreed that Dr. Jones deserved it, so he was given it, and we gave it to him that year at the banquet. His wife came out, and son-in-law, and so it was a wonderful celebration, because he had thought the profession didn't appreciate the work that he had done. So that was wonderful to have him, see him be happy and see him be honored by the profession. And he died a month later.
That's a lovely gesture.
Yeah.
And that sounds like you've been an inspiration to him as well.
We went back and forth. He was a clinician, so he was a family doc, just a regular, family doc. He had no intentions of doing anything other than serving the community he went to in Eastern Oregon. And then by happen chance, he stumbled on counterstrain and then switched his practice over to be almost completely looking at counterstrain. And so over the years, as he started to teach, he wasn't a natural teacher. He taught well, but he oftentimes especially appreciated guidance from people around him that were teachers, and to give him clues on how best to get information across. So yes, we worked hand in hand a lot over the years.
Throughout the years, you've not only worked as an osteopath and teacher, but also as the president of the American Academy of Osteopathy. And I wanted to personally know what thrives you.
And when you say what thrives me, do you mean what excites me, or what gets me interested, or what gets why I worked with the American Academy? So those are all different answers.
Best of both worlds for the first two questions, I'd say.
Okay. Service is a big interest to me. I want to serve my patients in terms of treating them the best that I can, so that they can get to the point of being as healthy as possible, whether that means increasing range of motion, decreasing pain, anything that helps their body to optimize the function, whether it's respiratory, cardiac, musculoskeletal, whatever it might be. So service to patients is one thing. That drives me in terms of seeing patients. Part of that service also is to osteopathic medicine, because osteopathic medicine has always been in the shadow of allopathic medicine in the United States. It's an interesting piece. We've come to a point where we've almost been successful to the point of destruction of the profession, which saddens me a lot. So in other words, when I say that, what I mean is osteopathic medicine in the United States has expanded to the point where when I started, 5% of the physicians in the United States were osteopathic and 95% were allopathic. Now, at this point in time, we have 25% of the students in school and in residency training, 25% are now osteopathic. So a tremendous increase, the number of schools, the number of students. So on the one hand, that's something to celebrate, the increase in the size. But the downside and the negative part of that is this profession has not been able to keep up with the traditional osteopathic part. So the part that I love the most is that integration between traditional osteopathic diagnosis and treatment, and also the traditional or medicine. As the medicine increases, that is getting further and further apart. And which means our students are having a difficult time getting training in the third and fourth years, their clinical years. And if you don't get training, it means you don't build confidence, you don't build skills. So by the time you're making your own decisions about what your practice looks like, we have a decreasing number of people going into traditional osteopathic medicine, whether integrated into another practice or whether it's as a solo practitioner just with traditional osteopathic medicine. So the third one that goes along with that is looking at the why is in terms of the teaching. One of the things when I was a student, again, I thought, oh, I'm going to go into these osteopathic hospitals, which no longer exist. There are no osteopathic hospitals left. But at that point, there are all osteopathic hospitals. Oh, this is where I'm going to get the training. I got just as much resistance as some of our students do, because many of the osteopathic physicians said, I'm a physician first, I'm an osteopath. Yes, I'm proud to be an osteopath, but I don't have time to use my hands for diagnosis and treatment. And from my perspective, it was, you don't have time not to use your hands. This is what's going to make the difference between you and another physician. This may make the difference between the patient getting healthy quicker, or maybe even being healthy in a way that they would not be just by using surgical procedures and medications. So I thought I need to be a teacher to go through and to try and help that part of education. So that's driven me in terms of looking at teaching. The third part of that is looking at the service to the profession. So the profession as a whole, they have the American Osteopathic Association and then the groups underneath it. And the one that I've worked mostly with, the American Academy of Osteopathy, making sure that that organization kept true to its principles. It's kept true to integrating osteopathic manipulative medicine into patient care, whether it was in a person who was doing surgery, family medicine, emergency medicine, pediatrics, obstetrics and gynecology. All of those areas need to have osteopathic medicine as a component part. Where the manipulation fits in depends on how the patient presents. But so it's not always at the top of the list. It's not at the bottom of the list. It varies, like all therapies, where there may be medications needed, surgical procedure may be needed, but those move up and down the list depending on the patient and the problem at the time.
Mm-hmm. You just talked about the rise of osteopathic students, not only students, but practitioners in America. What do you think was the reason for that increase?
The increase, the short answer is the demand. The demand is definitely there. We need more physicians, without question. The exciting part was to increase it with an osteopathic perspective. As I said before, the difficult part is if we're increasing our presence in terms of having more schools, having more osteopathic medical students, and more osteopathic physicians into the future, but they don't use their traditional osteopathic hands-on diagnosis and treatment integrated into their other practice, then to me the expanse in the numbers is worthless, because all we've done is expand the number of physicians
Mm-hmm.
and not expanded osteopathy.
Mm-hmm. And how much exactly do you value the philosophy behind osteopathy, and how do you try to teach the philosophy?
I think the philosophy is everything. That was what really caught my attention when I first read about osteopathy. It was just a one-page article in a book on alternative medical careers, and it went true to me in terms of looking at the importance of anatomy. And it's interesting because in the U.S., the influence of still is anatomy, anatomy, anatomy. And many places in Europe, the schools are even influenced a little bit more sometimes by Little John, who felt physiology. Now, Little John and Still taught together, and that they had that same argument. Still's perspective was anatomy drives physiology. So when I say anatomy being Still, he says it is the anatomy that goes on, whether it's the anatomy structure of the kidney or of the heart or of the lungs, that anatomical structure drives the physiology. And there was some disagreement between he and Little John. And so they go sort of hand in hand. The other part with that philosophy of structure-function relationships. In today's day and age, it sounds like, well, of course, everybody understands that, but that wasn't a concept when Still came up with that idea of looking at how important that reciprocal interrelationship was, because the anatomy and structure function were all a critical part of how he thought about patient care, how he thought about diagnosis. I've read accounts where sometimes students and patients would think he had fallen asleep because he'd sort of go into a phase where he would be thinking, and my imagination is he was going through all the anatomical relationships and going through, okay, this blood vessel goes through this area, this lymphatic vessel, we've got nerves going through here, and he's going through and thinking of which structure function relationships are most critical to the actual treatment of the patients. And then once that was clear in his mind of how he wanted to approach it, then he would go straight at the patient and work very quickly.
Mm-hmm.
But in that time before then, people would think, has he fallen asleep?
Mm-hmm.
Is he still with us?
I remember reading a story about Andrew Taylor Still, where he would sometimes leave the room with the patient for about, let's say, 20 to 30 minutes, just thinking about the solution, and afterwards coming in and just saying something like, you need to lose weight, for example. Mm-hmm. So there was a lot of emphasis on the diagnosis, I would say.
Yes.
And how much do you value diagnosis, and how much do you value using your hands in the diagnosis?
That's a great question, because one of the problems that I see in some of the schools is they are so focused on teaching technique that they're not teaching diagnosis. Once anybody has a diagnosis, they can apply a treatment. But the key is to find the correct diagnosis, an accurate diagnosis, and especially if you can find the diagnosis that is most key to that patient at that point in time, then you can go straight at the problem and apply a technique. But just throwing a bunch of techniques at a patient does not make for good osteopathic diagnosis and treatment.
Certainly. And the last question I wanted to ask you is what have been the greatest successes in your development of a treatment as an osteopath? That's probably a difficult one to answer.
Yeah. The question of what has been best in terms of treatment for myself, it really has been an evolution. And one of the things we try to tell students is you're in medical school for 4 years. You're in training for a minimum of 3 after you graduate, until depending on which residency you do. But you really need to be a lifelong learner. And that means reading articles on research. That means looking at new approaches that may come out. That means continuing to take courses, because you continue to build your information base, which builds your ability to palpate, which builds your ability to diagnose and to treat. So all of those keep on going. I always fear when somebody says, well, I don't need to go to courses anymore, I know enough already. That to me tells me you've just shut down your learning.
That's death.
Exactly. So I have always told people, and I approach this myself, I love still going to courses. Again, reading a new book, reading an article, talking to somebody who has a different perspective, even on something that I think I know pretty much about. Always get some new ideas. So seeing someone teach the same subject or teach a lecture that you may have given, always get a new insight, because everybody has a different perspective on that information. So when I go to a course, it may be I get information from the person that is leading the course. It may be that I get it from discussions in between the breaks. It may even be that the partner that I'm with, I actually get more from and more learning because of the way they approach the information and the way they integrate it. So you need to be a lifelong learner, which means continuing to take courses, which means continuing to keep your mind open and continuing to expand your ideas and your understanding of the profession.
As a teacher, how would you say, can you influence the way people think and especially love the process instead of just the accomplishment, let's say?
I think you can help to understand the subject and to appreciate that by different individuals by really showing them how they work and how they find interest in patients. The reason we have so many different areas of study, one is there's a huge body of information, but the other is people have different interests. So whether it be being attracted to children and that age group, or geriatric population and that age group, or sports medicine, or emergency situation, different situations get people more excited about working and engaging with the patient population. Each one of those has the ability to integrate and to use osteopathic thinking and concepts as well as its treatment and techniques. So what I try to get students to do is say, I tell them, I'm not trying to get every one of you to become an osteopathic manipulative medicine specialist. What I'm trying to get you to do is to think about how the body works, to think about what's best in terms of that patient for healing, and how to use your hands in terms of diagnostic and treatment, and to see where that fits in the treatment regimen and in the differential diagnosis. So of the fellows that I have taught over the years from several different schools, there hasn't been one that has gone into a purely osteopathic manipulative medicine residency. All of them has gone into another area. I've had them go into emergency medicine, into obstetrics and gynecology, pediatrics, general internal medicine, family medicine. So that's what gets me excited, is to say, okay, you are becoming a physician integrating. And it's another interesting thing when I meet, especially European DOs, and there's oftentimes a comparison between who's the real evolution from still, the American version or the European version. And I think both of us have fallen short. And what I mean by that is I think the European side has moved ahead of the American side in terms of looking at the variety of diagnostic and treatment approaches, different models that they use in terms of working with the patients, wonderful education in terms of the schools and treatment, but they have left the physician part. So that's a big difference, because Still was a physician. So whereas in the US, we have gone too much to the physician side, and we have not kept the osteopathic side as much as we should. So I'd like to see both sides sort of move back toward Still's idea of, I'm a physician, and my thinking is different. The physician thinking is different than a chiropractor's thinking, or a massage therapist thinking, or a physical therapist thinking. So that part of the practice is important, but I also want to see it expand. What I've seen over the last several decades is the only place, unfortunately, in the world where I think traditional osteopathy is shrinking is in the United States. I see it growing everywhere else in the U.S. It doesn't mean it's dead in the U.S. There are some tremendous osteopathic physicians, wonderful education, and some great students and people coming up. But because the profession hasn't honored its traditions as much as it should have, it's harder and harder for students to get that information and that education, so they don't incorporate it into their treatment. Whereas in Europe, it's become a separate area of medical approach and study, and has expanded all over the world. I've taught in Germany and Japan, Brazil, Greece, Poland. So it's been wonderful to see the students embracing these different areas and increasing their interest in osteopathy.
John Glover, thank you very much for your time. It's been a pleasure talking to you, and I wish you all the best for your course this weekend.
Thank you very much. It's been a pleasure for me too.